and it's a great pleasure to be with Professor D. Prabhakaran from Public Health Foundation of India. He's not only a great epidemiologist in the country working on chronic diseases for a long time, but also a good friend and colleague for the last 20 years now. So today we are going to ask questions about the burden of heart disease which is emerging in our country. What are various options in front of people, in front of policymakers, in front of the politicians to tackle this burden, and what's the role of Public Health Foundation of India? Dr. Prabhakaran is Vice President of Public Health Foundation of India. He's also adjunct professor at the University College London and the University of Atlanta, Georgia. So welcome Dr. Prabhakaran, and I welcome you to this program.
Thank you, Dr. Gupta. I just wanted to clarify that it's not UCL, but I'm a faculty at the London School of Hygiene and Tropical Medicine and at Rollins School of Public Health, Emory University. I'm also a cardiologist by training. Look forward to chatting with you.
Today we are going to talk about the heart disease burden in our country and how Public Health Foundation of India is trying to control that. So you have written extensively on the burden of heart disease and basically coronary artery disease, but not only coronary artery disease, but also the old friends like rheumatic heart disease, cardiomyopathies, infective heart diseases, also there with us. So what's your take on that?
So this conference has come at a very opportune time because we very recently completed the state level disease burden in India. And according to the state level disease burden, cardiovascular disease has emerged as the leading killer in India. Nearly 28% of the deaths in India is caused by cardiovascular disease, but there's a huge amount of heterogeneity in cardiovascular diseases. For example, in the south, in the west of India, and parts of Punjab, Haryana, etc., coronary artery disease has emerged, or ischemic heart disease has emerged as the major contributor to cardiovascular disease mortality. However, if you go to the northeast and eastern parts of India, stroke is a major contributor to cardiovascular disease. And in the central parts of India, parts of Chhattisgarh, Madhya Pradesh, Orissa, it's rheumatic heart disease which is a major contributor. The other important thing that we need to note is not only is the prevalence very high, but it has risen very rapidly. In fact, from 1990 onwards till now, there's almost a 60% increase in the burden of cardiovascular disease in India.
So what do you think the root causes of this burden?
So when we look at it, there are multiple causes. Most people who are looking at upstream determinants would say it's the rapid lifestyle change induced by urbanization, globalization, increased use of tobacco, increased mechanization, reduced physical activity, and so on. And that's an important reason. But there are other reasons too. And I think one of the major reasons is diet. Our diet is very rich in carbohydrates, so we have very high propensity to develop diabetes. The second is that we consume salt in high quantities, which also is one of the reasons for high blood pressure. The third, of course, is low physical activity, high alcohol consumption. So these are all multiple causes on a background of high risk. It has been shown that children who are born with low birth weight and who put on weight rapidly have higher propensity to develop diabetes, hypertension, and cardiovascular diseases. And that could be one of the reasons. There are, of course, genetic factors, and the biggest elephant in the room currently is environment. Air pollution is an important factor. Air pollution can produce endocrine disruption, can cause inflammation, and can increase the risk for heart disease. So there are multiple factors, and I would say it's multifactorial.
So in terms of the disease burden, we always look at solutions. So is Public Health Foundation and your organization providing solution to the problem? Because unless we have solutions, we know the problem is there. What are the solutions at the policy level, at the physician level, at the personal level?
So before I talk about what Public Health Foundation of India is doing in the chronic disease space, it's important for me to describe what Public Health Foundation of India. It's a public-private partnership which was founded in the year 2006 with support from the Government of India, the Bill and Melinda Gates Foundation, and private philanthropy. So essentially it works in multiple areas, but one of the important portfolios is chronic disease prevention. And in that, I head the center which is called Center for Control of Chronic Conditions and Injuries. which is also a part of an international collaboration amongst 4 groups: the Public Health Foundation of India, the All India Institute of Medical Sciences, the London School of Hygiene and Tropical Medicine, and the Rollins School of Public Health, Emory University. Now, the main portfolio of the Chronic Disease Center is 3 or 4-fold. First, the mechanism of cardiovascular diseases has not been well understood in India. We have always been relying, for example, on the Framingham risk or some international risk to identify risk for cardiovascular disease amongst Indians. So in that direction, we have established a cohort or maybe multiple cohorts in the cities of Delhi, Chennai, Vizag, Sonipat, and even in rural areas of Vizag and Sonipat, through which we are trying to identify the links between risk factors and cardiovascular disease. As an example, let me give the example of diabetes. Diabetes, a lot of us believe, is because of lifestyle modification, increased weight, obesity, insulin resistance, and so on. But from our research, it appears that insulin resistance is not the most important cause, but it appears to be beta cell dysfunction. And there could be multiple reasons for beta cell dysfunction, and we need to identify those reasons. The second thing is, if you look at the pattern of myocardial infarctions in India, we seem to have very high ST elevation myocardial infarction as compared to Western population. The reason could be high thrombogenicity, high smoking. We don't know. And smoking is not such a major factor in the Indian population as compared to the US population. But clearly, there could be other reasons, and the cohorts will answer these questions in the next few years. The second area of work that we are doing is in trying to identify low-cost solutions and improving quality of care both at primary, secondary, and tertiary care level. Just to give an example, in terms of low-cost solutions, we have done multiple research in multiple settings that includes creating a cadre of physician assistants, creating a nurses, community health workers in the management of chronic diseases. They are empowered with an electronic decision support system, and we have found that this has a huge bearing, particularly even in tertiary care centers, because it saves time for physicians. It saves at least 8 to 9 minutes from patient consultation time. So the doctor can actually concentrate more on the art of medicine than trying to get nitty-gritties of blood pressure, heart rate, which the nurse can actually do it. The nurse provides the lifestyle advice, and we have shown that this actually improves blood pressure control, improves HbA1c control, and therefore it's got a huge bearing. The third, in terms of quality of care, is we attempted a large cluster randomized trial in Kerala in 63 hospitals. It improved the process of care, improved the quality of care, but it didn't change the outcomes. But that's also important to improve quality of care, where we just did 4 simple things. We provided discharge instructions, we provided audit and a feedback loop to these people, and we looked at, asked them to check the process of care at a management level, and actually these things really improved the process of care. The third area where we have worked is in cardiac rehabilitation. There is virtually no cardiac rehabilitation in this country, and therefore we said, instead of establishing the conventional cardiac rehabilitation, the Western-based cardiac rehabilitation, we thought, why not use yoga as a mechanism or an alternate for cardiac rehabilitation? And we have demonstrated, we just recently presented that in the American Heart Association late-breaking study, and was very well received. We are writing that paper up. Then in terms of the policy domain, we recently worked on the Disease Control Priorities Project, which is funded by the World Bank and the Bill and Melinda Gates Foundation. And I, as the lead editor, along with several international collaborators, submitted that report, which essentially has several cost-effective interventions, but not only it focused on cost-effectiveness, it focused on financial protection. Suppose we have 100 crores with us, how do we use that to protect people from getting into, when they have catastrophic illness, getting into poverty? So that's one of it reviewed the whole range of literature for several diseases and ultimately summarized them easily for policymakers to adopt. So our work ranges from identifying mechanisms to finding low-cost solutions, but at the same time synthesizing that information and disseminating it to the policymakers as well as the general public.
So what do you think are the barriers to implementation of quality care? Because I believe that quality is the single most important criteria. You have blood pressure control, you have blood pressure treatment, but unless you have controlled blood pressure, it's not going to benefit the people. You have set up intensive care units across the country. Unless you have good people, they will not be able to So you're doing some training programs also?
Yeah, I think you hit the nail on the head correctly. One of the things is we may have wonderful programs, we may have wonderful mechanisms of controlling, and these are all very simple things. But if you don't have the people to do it, it's going to be a problem. In fact, if you look at cardiologists in the country, even in the best case scenario, we may have around 6,000, 7,000 cardiologists. I think it's much less than that. For a population of 1.3 billion, is that adequate? Therefore, chronic disease management, cardiovascular disease management has to be at the primary care level. And therefore, we have embarked on a very ambitious primary care physician training program. We run 11 programs right now in the management of diabetes, in management of cardiovascular disease, in hypertension management, in chronic obstructive lung disease, thyroid, so on and so forth. And these are very, very popular. And these programs have been developed in consultation with global experts, in consultation with knowledge partners, academic partners, and through a set process which improves the quality of these presentations. We teach the primary care physicians in a very standardized fashion. The courses are delivered all across the country on a Sunday over a 5 or 6 hour period in a very standardized way. This has been extremely successful. In fact, we have trained almost 25,000 doctors in the primary care physicians in the last 5 to 6 years. It has won several accolades and awards. In fact, we recently won the Quality Council of India Award, the Platinum Award, which is the highest award. It's won award from all the organizations like CII, ASSOCHAM, FICCI, the PhD Chamber of Commerce. So all the industry groups we have won awards. Now it has been scaled up internationally. In fact, Africa is adopting this program. Myanmar has adopted some of our programs. Nepal has adopted some of our programs. We are in negotiation with China and Sri Lanka. So clearly people feel that there's a need for these primary care physician training programs, and that's going on scale.
So in the last 1 year, the talks at the highest level of the government has shifted away from providing usual care into strengthening the primary healthcare system as well as to provide health insurance to poor. So how do you think Public Health Foundation can help in both these projects?
Yeah, Public Health Foundation of India has actually been involved in some of the developmental process for a very long time. But I think the Ayushman Bharat gives us a tremendous opportunity in terms of health system design, particularly in terms of the primary health care. The health and wellness clinic, which the government proposes, 150,000 of them, is an excellent idea, particularly for prevention and management of chronic conditions, because they don't have to go to a higher center. Higher centers should be reserved for people with complications or for people who cannot be managed at the primary care level. And I think PHFI has developed curricula, PHFI has trained these physicians, PHFI is working with allied health professionals to contribute to this care. PHFI has also provided several state governments in maintaining its health accounts. For example, how do we spend? If we have 10 crores with us, how do we spend? So those are the kind of work it has helped. It also has helped in the evaluation of insurance programs. So there are multiple pieces of work PHFI has done in this domain.
Recently, I was reviewing the issue of risk to heart disease, and there are 3 studies. One is the PURE, which showed that in spite of having low risk factors, Indians have high mortality, which is the paradox. Secondly, the global burden of disease study, which you just said, has clearly shown in the last 25 years, India or South Asia is the only region in the world where the mortality is going up. And the same is true for the million death study. From 15 years, in the last 15 years, the age-adjusted mortality from heart disease has gone up. So do you think that all these interventions are going to help to reduce the burden, or they are going to help us to achieve decline in mortality from heart disease?
I think we need a multi-pronged attack in terms of reducing heart disease mortality. We need a systems level approach. I think once the health system is strengthened, because if you don't have that health system connectivity, whatever solutions that you may have, you won't be able to address those issues. And therefore you require that health system connectivity. And I think the government is working in the right direction in terms of reducing that. Of course, along with that, you require non-personal policy measures, particularly in terms of tobacco control. And I think India has done exceptionally well, because I think in the last 6 years or 7 years, There's been a 5 to 6% reduction in smoking. Where we are not doing well is in the non-smoking forms of tobacco, and I think we need to work there. I think trans fat reduction is another area, but there are several areas which are within the domain of our culture and our beliefs. For example, it's easier to reduce salt in industrialized countries or in the Western countries. In India, we add salt when we cook food, so that's going to be difficult unless we get behavior change. But it is also a challenge as well as an opportunity. Opportunity here because if you look at the future, maybe 20 years from now, we are going to get more and more processed foods, so we can learn from the West. The Prime Minister's smart cities idea is a great idea because it gives you an idea in terms of how do we build parks, how do we build green space, how does the built environment influence this, how does the transport system influence. So there are several high-level interventions at a population level which can bring down this burden.
So, given the limited political choices, what is we have low-hanging fruits and we have high-hanging fruits. So, what do you think should be the first or second priorities of the government?
So, I think the three areas which the government, this has also been identified by several others, and I think the three areas which we should really focus on if we need to address the cardiovascular disease burden, and we may add one more dimension, is tobacco control, high blood pressure control, and secondary prevention. In addition, we also need to focus on diabetes because diabetes is also emerging very rapidly, and the bigger problem is the pre-diabetes. Pre-diabetes in urban locations is almost 1/3 of the population, and it gives us an opportunity to prevent people from progressing to diabetes. So if we address these three issues by improving the human resources, by ensuring that the essential drugs which are inexpensive are available in the system, by improving secondary prevention, I think we will do a lot.
What's your take on the quality issues? So I think that is the most, I believe there is a more important domain of the whole prevention area, that unless we have high quality, low cost interventions, high quality, low cost people in the system, things are not going to change. So what do you think of that?
I think quality is extremely important, and in that direction we are working with the Quality Council of India, working with healthcare managers, people who are at a lower mid-level of healthcare system in improving quality processes in health system. And that course is very popular because it actually teaches the nuances of quality. It has some theoretical component, but several things in our day-to-day practice as cardiologists, for example, if we make it prudent that, okay, when I ask us our question, when you are discharging a patient with heart attack, are we prescribing all the 4 or 5 things that are really required? And if so, and we can say that we are not doing this because of these reasons, then we would have done our job.
Well, thank you. We had a nice discussion.
Thanks.
And I hope we get somewhere. Thank you.
Thank you.